I invite Dr. Pradeep Sharma to give his talk on paralytic strabismus. And after the first three amazing talks, it's a tough act for him to follow. So we look forward to your talk, Dr. Pradeep.
Thank you, Dr. Chitra and Dr. Murli, for giving me this opportunity to be here. I think it's a tough time because I have to wrap it up in 10 minutes. And I hope we just do an update on this. So as we see, third nerve palsies has been talked about neuroimaging earlier, but just to make it simpler, what we usually follow is that if it's pupil sparing third nerve palsy, we need to investigate the ischemic vasculopathic causes in the management and look for simple culprits like the blood pressure, blood sugar, lipid profile, homocysteine, and also the ESR and CRP, because some form of giant cell arteritis may also present as third nerve or sixth nerve palsy. So that should be kept in mind. And then specific investigations should be done as required. Some of these cases may also require imaging, and we'll talk about what. Myasthenia gravis should also be ruled out, but the main thing is that they may be again be pupil sparing. And if you have an unexplained pattern, the simple thing which I follow is in the clinic, the ice pack test, which is very effective. It almost like 70 to 80% cases, and just takes about 2 minutes to rule out ocular myasthenia gravis. So pupil sparing cases, we should investigate for the ischemic causes, as I said. But if there are no pupillary involvement, look for delayed pupillary involvement in the subsequent 5 days and recheck every 4 to 6 weeks. Usually the vasculopathic third nerve palsies start recovering in 4 to 6 weeks time and fully recover by 3 months. If there is no recovery happening in the first week, or the pupil dilates, or additional neurological features are happening, or there are aberrant regeneration, or there is a progress of palsy, do not hesitate to do an imaging. So imaging should be done in these cases. And if there is a third nerve palsy with pain, specifically an MRA would be called for. If pupil is involved but imaging is negative, then even a neurological consultation and a lumbar puncture should be done. So when to do imaging, that's what should be kept in mind. I think we had a very nice talk by Dr. Srinivasan on the details of the findings. I would not go into that, but these indications we should keep in mind as a clinician. Cases which have a pupillary involvement, of course, we should be looking for, there may be intracranial space occupying lesions. And as has been talked about, why there is a pupillary sparing, because of in the vasculopathic, because of the nerves which are having blood supply outside. The aneurysms can also be causing the third nerve palsy. But imaging can sometimes also tell us about those cases which may be considered as sixth nerve palsy but are not true sixth nerve palsies. Now, this is a deviated muscle and not a paralysis of sixth nerve, as has been shown by imaging. And these are cases of high myopia, and these also should be kept in mind. They may be the sagging eye, the heavy eye, or the knobby eye, which will be picked up on imaging. So another indication for imaging would be these conditions, which will reveal the diagnosis. The congenital cranial degeneration disorders are other conditions in which imaging does help, and these are actually paralytic strabismus, not acquired, but in the congenital phase. So these also should be kept in mind, and here the high resolution imaging does help in finding out the problems in the third nerve, or the in case of Duane's retraction syndrome, the sixth nerve, the third nerve in cases of congenital fibrosis extraocular muscles, and the Mobius sixth nerve. So these conditions I would just like to keep in mind for the people. Once we have a diagnosis made, how do we manage? Now, in third nerve palsies, we usually follow up every 6 weeks for recovery. If there is no recovery in 6 to 9 months, then only surgical management is thought of. But short of that, can we do something? Yes, Botox has been talked about, and it has been there for quite some time, but its role is limited. Even the recent study from the Korean journal, which has talked about the Botox, it has shown that in 60% of these cases which were vasculopathic recovered. So it's majorly the vasculopathic cases which are going to recover in 3 months' time on its own. So it doesn't serve much. But if, yes, the patient wants an expedited recovery, then Botox can be injected in the contralateral muscle to have an effect. But these effects are always short lasting. Maybe by 3 months or 4 months, they disappear. Another thing which has come in the purview is the bupivacaine injection. So the bupivacaine, or which can be, but the studies have shown that we require to have a higher concentration of bupivacaine than what we normally use. The injected volumes have to be more than 1 ml, but then that becomes a problem injecting into the muscles. The overall change in the ocular alignment is not very good. It's maximum seen about 10 to 12 prism diopters. Even studies done by Dr. Alan Scott did not appear to be very promising. So it's just an adjunct in addition to the Botox that he was advocating, and not on its own as a therapeutic measure. So if there is a third nerve palsy, what do we do? Mostly we do surgeries. And if the eye crosses the midline, we do recess resection. Nowadays, instead of resection, you may do plication. We do not go into the videos. Recently, the MR mini plication is another additional thing which helps us in situations which are in between the cases which require a full plication, but we can just use a central suture, 4 millimeters or 4.5 millimeters, and then give an additional effect to the paresis. Relieving the FDT is very important. So many people I see have done cases of third nerve palsies which have failed, partly because they have not seen the post-operative FDT being fully released. You don't have to go by the recession amounts. It has to be an FDT to be relieved fully. Large LR recessions are called for in these cases, maybe to the extent of 18 to 24 millimeters of LR recessions. And that is why sometimes we do a periosteal anchoring of the lateral rectus. So like in this person who was himself a doctor, I did an LR recession of 24 mm and an MR plication, which turned out to be effective in his case. Cases which have been operated elsewhere, we have sometimes explored and then do a re-recession of more than 25 mm, and that works in these cases. So what do we do in cases in which the eyeball doesn't move beyond the midline? The things which have come up recently is the transposition of the lateral rectus, the split lateral rectus medially transposed, or nasal transposition of the split lateral rectus, NTSLR. And this is a very effective procedure which is done in cases of third nerve palsies in which the eye does not cross the midline. Cases in which there is a hypertropia preoperatively, we have done a full transposition of the lateral rectus without splitting inferiorly, and that also yields very good results. So that is something which can be kept in mind. You need not always split the lateral rectus. You may transpose the lateral rectus full width inferiorly if there is going to get a correction of hypertropia in addition to the exotropia. Cases which have a pseudotosis may require a contralateral superior rectus weakening, a fixation duress procedure. And cases in which both may be done in, that means the NTSLR as well as the fixation duress procedure to correct both the problems in third nerve palsies. Cases which have a very severe exotropias of 90 prisms, we have done periosteal fixation of lateral rectus and also sometimes a periosteal anchoring of the globe medially to correct the exotropia of these large amounts. Aberrant regeneration requires a different management, and these third nerve palsies, we have to look for each case individually. Some cases like this particular individual has no exotropia in the primary position. The aberrant problem is only of the lid. So this case only needs counseling, and we may not do any squint procedure in these cases. But cases in which there is an exotropia, it's worthwhile to operate on the contralateral eye to take advantage of the aberrant innervation to correct the ptosis in addition to the squint. Now, this is an individual who had a left third nerve palsy in which there has been a contralateral eye done, and you can see that the ptosis also has been corrected after the squint surgery. Cases in which there is an acquired inferior division third nerve, we may do an inverse NAP procedure, a modification in which what we nowadays do is no recession of the lateral rectus which is transposed, just the medial rectus is resected and transposed. So this modification works well and increases the inferior tonus as well as corrects the exotropia. So this is a modified inverse snap procedure in a case in which a right lateral rectus has been reinserted at the inferior rectus with no recession, and the medial rectus has been resected 6 mm to correct the exotropia and also improve the deviation in down gaze. Cases may also be improved by some other procedures like what we have, the Scott procedure in the contralateral eye. This is another newer advance in the squint surgeries. that may help us correct the incomitant strabismus, which is there in these cases. By correcting in specific direction you want a correction, you can use the Scott procedure. Like in this case, a Scott procedure, resection of 6 mm and the recession of 12 mm on the lateral rectus of the contralateral eye has corrected this incomitance. So important points to remember: deviation in the primary position, look for incomitance, look for the fixing eye for the target deviation. If suppose there is an eye which has no vision, you may have to choose the eye which is fixating. If it is a paralytic eye, a larger correction may be required. FDT for the LR is very important to keep in mind at the end of the surgery, and you may require to do supramaximal recessions in these cases. An option of contralateral muscle surgery should be kept in mind. In sixth nerve palsies, we are little fortunate because we have the vertical recti which are intact, unlike the third nerve palsies. And here we may use the transpositions of the vertical recti, either a full tendon width or a partial tendon VRT. Or nowadays we have the Nishida's procedure or the belly transfers, which can help us in correcting the cases which cannot be corrected by refresh and resect procedure alone. So here there is a non-adjustable partial VRT, and this is showing you a cross-acting VRT to enhance the effect of the vertical transpositions. So these are the advances which we are nowadays following in correcting these cases of paralytic strabismus, which are large angle deviation in primary position, to correct the primary position as well as to improve the abduction in cases of sixth nerve palsy. The modified Nishida's procedure, or the belly transfer of the vertical recti without splitting the vertical recti and without disinserting the vertical recti, is a good advance to make use of, as it doesn't sacrifice the anterior segment blood supply and gives the vectorization of the vertical force. So these are cases in which we have achieved the correction. There is a review which our group had done of vertical rectus transposition procedures for lateral rectus palsy, a systematic review. But mind you, the important thing is that there is a lot of variability as per the case, also as per the surgeon and his technique, that the results may have a lot of variation. Superior oblique palsies, we have to remember that we can correct it in different way depending upon the involvement, and the NAPS classification comes handy in these cases. Remember to keep these things in mind, that in which deviation, in which gaze is maximum, and which procedure we would like to do. I think with time being constrained, we'll not go into the details, but just keep in mind that different procedures are available to correct these sixth nerve, the fourth nerve palsies. Whereas this is an anterior. I think the anteronasal transpositioning is very good procedure for correcting very severe inferior oblique overactions in cases of the superior oblique palsies. In cases which are severe superior oblique palsies, one may do the Harada-Ito procedure, which corrects the torsional component. In such cases, usually the vertical component is not much, and this yields very good results. Recently, I think there are some people like Jonathan Holmes, who has been talking about doing a resection of the superior tendon rather than just an advancement. So just to cut the story short, we have to be a squintellectual to keep the individual case in mind. What is the requirement of that particular case? And mind you, we can usually achieve to correct the binocular alignment in at least in the primary position and in the down gaze, if not in all the 9 gazes. And that should be our goal, to restore the binocular vision and stereopsis. Thank you for this present time.
Thank you so much, Dr. Pradeep. You know, you're always the best. Can you stop sharing? So,
Yeah.
Murli, can you ask some questions?
Yes, sir. Sir, regarding the LR to MR transposition, there have been some reports of a paradoxical severe undercorrection. So how do we avoid it, and what do we do in case we have a severe undercorrection after an LR to MR transposition?
Yeah. So as I said, Murli, that this is depending on the technique, that how are you doing. And if you have a lateral rectus, usually the lateral rectus is going to be little longer compared to the on nasal shift side. When you transpose it, you need to sometimes do a cross section of the split ends. Do I make myself clear? That in that case, what we do is the upper end of the lateral rectus, I would bring across on the inferior end of the medial side, medial rectus, and the inferior end on the superior side. So there is a cross section which will give us the vectorization of the force. Some people have also done a Foster augmentation on these cases. At the end of the surgery, you have to see on the table that you have achieved a 10 prisms of overcorrection in these cases. Then you do not usually have an undercorrection.
If the FPT is moderately positive, can we still do a LR to MR transfer? Or
Yes, if it is moderately positive, the LR transposition can be done. If it is, unless it is a very severe tide, it's possible to do a nasal transposition of the LR. In such cases, you may not have to do any vectorization because these are already tight lateral recti and they will yield overcorrection. So you have to be careful that you may rather do a recession of these lateral recti on the medial side. So on the table, again, you will have to see that are you doing an overcorrection of more than 8 to 10 prisms? If that is there, then recess these two limbs so that you do not have a esotropia later on.
Thank you. Thank you, Dr. Pradeep. Thanks a lot.